So I think just to be mindful of everyone's time, we're going to go ahead and get started. Thank you all so much for joining us. Welcome, bonjour, Ani. Before we begin, the North Simcoe Muskoka Hospice Palliative Care Network would like to acknowledge that we are situated on the traditional, ancestral, and ceded land of the Anishinaabe people. The Anishinaabe include Ojibwe, Ottawa, and Potawatomi, nations collectively known as the Three Fires Confederacy. We are dedicated to honoring Indigenous history and culture and committed to moving forward in the spirit of reconciliation and respect with all First Nations, Métis, and Inuit people. Thank you for joining us for the first session of our Tools in Your Toolbox series in partnership with Palliative Care Echo Project. The Palliative Care Echo Project is a 5-year national initiative to cultivate communities of practice and establish continuous professional development among healthcare providers across Canada who care for patients with life-limiting illness. I would like to now introduce our guest speakers, Nancy Good-Kennedy and Julie Layton-Phelps, who will be discussing the surprise question in palliative care. Welcome, bonjour, Ani, Nancy, Julie.
Thank you, Amanda, and hello, everyone. My name is Nancy Good-Kennedy.
And I'm Julie Layton-Phelps.
I'm a certified hospice palliative care nurse consultant and education facilitator with the North Simcoe Muskoka Hospice Palliative Care Network. And as a sidebar, my goal is to improve the lives of patients and families experiencing life-limiting illness through the delivery of education. Thank you.
I also, like Nancy, am a nurse consultant with the North Simcoe Muskoka Hospice Palliative Care Network, and I strive to provide excellent palliative care throughout my client's palliative journey.
So now that you've heard a little bit about us, we would like to know a bit about you. So if you could please take a moment, we're going to pull a poll up here, and we'd just like you to take a moment to respond to that, please. So the poll's been submitted, and we'll just wait to take a look to see. I'm sure we have persons from many different locations all here to share and gain knowledge with us. So thank you again to Pallium for the opportunity to share such knowledge. By the end of our time together, you will be able to not just define the surprise question, but implement it into your practice using some shared common knowledge. Our expectation, of course, is that you recognize the need for an early approach to palliative care. So as we move through today's presentation, we're going to explain this question more clearly, introducing you to other forms of the question as well. We see here that most people die of chronic disease. In fact, according to the World Health Organization in 2019, top causes of death were chronic in nature, including cardiovascular, like ischemic heart disease, respiratory, including COPD, and then finally, neonatal conditions. We cannot stress enough how important it is to recognize the initial stages of these diseases and have conversations that support a truly palliative approach to care early in this trajectory. Clinicians have long identified the challenge of accurately making a diagnosis as being a barrier to patients accessing end-of-life care. Many tools have been developed to help with this process. The surprise question has gained support as a simple, practical way of identifying patients at high risk of dying. The beauty of this question is in its ease of application, as you see outlined here. Many general practitioners say some patients have a slow disease progression with even periods of relative stability, and others experience a rapid decline or a disease trajectory with acute deteriorations. In daily practice, general practitioners often struggle to accurately predict disease progression in individual patients. Therefore, palliative care is not always timely, which of course is our goal. So Dr. Marie Bakatis, internationally recognized in pain and palliative care scenes, Doctor of Nursing and coordinator for the project called Enable. I really like this. So Enable is an acronym for Educate, Nurture, and Advise Before Life Ends. This project launched a plan to explore answers to the questions pondered about people who were facing a new diagnosis of advanced cancer. The Enable research continued to lead findings that patients' quality of life and survival was improved, and stress and depression decreased by receiving palliative care support shortly after a cancer diagnosis. Would I be surprised if this patient were to die in the next 12 months? The surprise question is just a tool to get people thinking differently about their patients. It's a mechanism to facilitate discussions on palliative care. It is about those who need attention with respect to issues of decline and death, not just those who are surely going to die within a specified time frame. The surprise question certainly has taken on a few different versions, like the emergency physicians who tried, would I be surprised if this patient were to die this hospitalization? Or the primary care provider in older patients, would I be surprised if the patient died in the next 2 years? Even the long-term care centers that used, would I be surprised if my patient died this season? One way or the other, the goal is to identify patients that are at a high risk of mortality in a particular time frame. The question was designed as a clinical tool that general clinicians would utilize willingly and routinely to identify patients at risk of dying in a year. This leading to more appropriate care planning, including what matters most to these people as they live while they die. Would I be surprised if this patient died this hospitalization, or in the next 3 months, 6 months, or 12 months? Would I be surprised if this patient was alive after 12 months? But here's a bit of a different twist. This question was added to the original surprise question to improve timely identification of palliative care needs. If the original surprise question were answered as a no, then the combination of the two questions, called the double surprise question, was implemented to minimize the risk of missing patients and to actively monitor those with complex issues that were in fact in need of supportive services. Would I be surprised if this patient were still alive after 12 months? It seems that we're better at recognizing life over death. In our ever-changing world, it may become all too common to overlook specific indicators that do, in fact, lead to decline in functional status, which of course leads to increasing needs. When answering no to the surprise question, be sure that conversations are happening about what they would and would not want at the end of their life. It is only through these goals of care discussions that their wishes for such things as repeated hospital visits, life support, and CPR can be determined. Thankfully, the surprise question is not a standalone tool, but as noted, it can be supported by use of many tools, including the palliative performance scale. As you see in this slide, all declines, whether rapid in metastatic cancer, erratic as in chronic disease, or gradual decline, as we see in people with frailty, dementia, or stroke, they all present themselves with the opportunity for rich conversation, again, with the goal of providing them with the right care at the right time. The final stage of life is both unpredictable and uncertain. Reserving palliative care as being only appropriate for the end of life care is very misleading. There are many reasons that this can happen. Often it's due to lack of resources and education on delivering difficult conversations, particularly initiating them. What we do know is if clinicians wait until the patient is too sick, that the patient, the family, and even the care team miss out on delivering high-level quality care at the end of life. It is certainly challenging to assess the right moment to start palliative care, but by pulling together clinical judgment and intuition with a good mix of pathology and clinical findings, will support a rate of decline and actually help practitioners to see the individual needs rather than the exact timelines. This trigger for goals of care discussions then allows us to acknowledge that people need different things at different times. Implementation of the surprise question happens as we have touched a bit on this information. So let's move forward and we'll discuss the specific topics. Here we're reminded of the multiple opportunities to implement the surprise question. In my readings, it was apparent the surprise question would have a higher rate of adoption into practice if it were completed with intention. So purposely planning these conversations at each health assessment, especially when there has been a change in condition. Also useful to incorporate the language into daily huddles and community rounds. Remember, we're looking to identify a need for further conversations. So death is not an exact science. It's only a rough guess. The surprise question is not meant for prognostication, but to be used alongside other tools that helped prompt advanced care planning discussions. These heart-to-heart discussions enable more people to live out the final stage of life as they choose with well-coordinated, high-quality palliative care. I'll turn it over to Julie.
Thanks, Nancy. With advancing treatments, with advancing treatments, including chemotherapy, surgery, radiation, and the ever-changing and addition of new medications, people are living longer with their disease. Often with active treatment, palliative care discussions and everything that palliative care entails are not discussed by oncologists or even some family doctors. However, this is a great opportunity to start these important decisions. Prognostication and palliative care, an illness trajectory or disease progression can be used in estimating a timeline of a terminal illness. Granted, this is easier to do in a cancer diagnosis versus a chronic disease. Terminally ill people want to know how much time they have left. They want to be able to make those final plans. Benefits to an early approach to care. Studies show that the early onset of palliative care can have multiple advantages. This includes improving the quality of life, and in some studies, it has been proven that life can be prolonged in some people, usually by 2 to 3 months. And this may be the time that they need to get those final plans completed and accomplish any wishes that they'd like. It also addresses unmet needs of the patient and their family, whether it's advanced care planning or symptom management. Assess if a palliative care specialist referrals should be done at this time as well, or can it hold off a little longer? Provide opportunity for goals of care discussions. At least get these goals of care discussions going. The goals of care certainly can change throughout the illness trajectory all the way up to the end of life. But having patients realize what they can do, what kind of goals they can achieve during this time is important. Optimizing symptom management, whether it's from active treatment, from the chemo, or from end-of-life symptoms. Triggering an early hospice referral, easing that worry, communicating those wishes that that's where they choose to spend their final weeks. Provide opportunity for health teaching to make informed decisions regarding their medical care. Many do not realize what is available to them. So if you ask that question, would I be surprised if my patient will die in the next 12 months? If you answered no, that you're not surprised, then this is the opportunity to start those discussions on advanced care planning, any treatment decisions, whether active or comfort, some goal setting, and start an early palliative approach to care, even if they're seeking that active treatment. This prompt should initiate the health teaching that is required for the patient and the family to make informed decisions about what they need or want now, as well as in the future. It should also trigger more advanced and comprehensive assessment. For example, the Palliative Performance Scale, PPS, or the ESAS, head-to-toe assessments, and possibly the rated deterioration. This way, the patient and family can have the time they need to make decisions, but to also live a quality life. There was a study that was performed to support the use of the surprise question, and also adding that second surprise question that Nancy talked about earlier triggers general practitioners to increase the thoroughness of their palliative care planning. So the question, would I be surprised if this patient were to die in the next 12 months, was thought to be easy to apply in identifying those in need of palliative care. But that particular question has a broad approach. The aim of the study was to determine if adding the second or more specific surprise question, would I be surprised if this patient is still alive after 12 months, would improve planning for a palliative approach to care. The combination of the two surprise questions actually encouraged the GPs to make more specific plans for anticipatory palliative care. And it was actually, when I had read it, then it's, basically the docs had a better chance of eliciting a proper response. And also rephrasing the surprise question definitely may give different answers based on how the client themselves interpreted it. Implementing the surprise question into clinical practice. A panel of experts suggested that a no answer will trigger the clinicians to perform a primary palliative care assessment or screening for unmet palliative needs. The question can be helpful in identifying patients at risk of medical decline and death in a certain time frame when it's actually used as part of a larger assessment combined with those validated tools. This allows physicians to bring up the topic of palliative care instead of the client doing so. They may not realize they are advancing in their disease process if there's no indication from the doctor. Reasonable components of the primary palliative care assessment triggered by a no includes not only the physical assessment, but the psychological, social, and spiritual issues that may arise. Identification of whether the patient completed any advance directives, power of attorneys, anything that they may need to settle guardianship if they have children. Assessment of the patient, family, and/or surrogates' understanding of what the current underlying illness is, what are the active and comfort care treatment options that are available, and the trajectory, if at all possible. It also includes assessment of decision-making capacity, engagement and honest conversations about prognosis and medical expectations. And often this is what the client wants, is their doctor or other clinician to be honest with them, open and honest, and to not skirt around or sugarcoat things. Consideration of whether a hospice referral would be appropriate now or a little bit later on. Consideration of whether a palliative care consultation may be beneficial now or later on when symptoms become more burden. Elicitation of the patient's care preferences and values. This means having advanced care planning conversations as well as the goals of care. Place of death and any final wishes that the patient may want to do, or even some legacy work. Several professionals now recommend providers have multiple advanced care planning discussions with their patients over the course of a serious illness that allows the patient to have adequate time to plan their future, to articulate their preferences even early on in the trajectory. And as I said before, this may change as the person becomes more towards the end of life. Routinely reevaluating and building upon those preferences. It may also take the client time to grieve their new diagnosis or a change in status where active treatment is no longer an option. Using particular language once a palliative approach has been identified is key. So advanced care planning and goals of care conversations that are triggered by the surprise questions, what can you say? Obviously, using simple, truthful, and direct language is what is best. I can tell you what I commonly see in patients with your condition is one example. Would you like to know what the next year might look like? What are your priorities if your time is limited? What do you want to accomplish in that time? It may help you to make plans. We're in a different place or phase of your health now. Sorry about that. Sure. What is most important to you? And this could be for their families, it could be for themselves, in regards to all the planning that may need to be done. As Atu Gawad said, the point of prognostication is not to be right, but to help people prepare. And we have several references that you can view on your own as well. So we'd like to thank you for joining us today, talking about the surprise question. This is just a short introduction into the benefit of implementing the surprise question into your practice. This is one presentation in a continuing series. We do hope to see you all next time.
We can open the floor to some discussion.
Hi, it's Sue here. Do you find that the general practitioner tends to, if they've asked this question of themselves about a patient and answered no, I wouldn't be surprised if this person died in the next year, do they tend to automatically jump to requesting a palliative consult from a specialist?
I personally, Sue, in my experience, I've seen both sides of that coin. So I do have a group of, I would say, family doctors that maybe don't have the in-depth experience that a palliative care physician may, where yes, because they're uncomfortable. I think I mentioned maybe a little bit earlier on that sometimes lack of education or just not having developed those skills to initiate conversations, when they realize that, yes, this patient may very well pass away within the next year, it will prompt that physician or that caregiver to go directly to a consultation. And I never really see that being as a problem. But what I do see is that it's really super important that we mentor those persons with us, not that we just go in, do a consultation and leave our notes on the chart, right? It's so much better for both sides. if we can actually have them with us and sit through the consultation. So that's been my experience. I don't know, Julie, if you have anything to add to that.
Basically the same as Nancy's. It depends on the comfort level of the physicians. Now, general practitioners deal everything from pregnancy all the way to death, so their breadth of knowledge has to be huge. A lot of my docs in my areas that I cover, some are very comfortable with palliative care, many are not. They will refer on when it is appropriate. Often we discuss in our community rounds when we maybe should carry on, because we do have our palliative docs on board with us, and sometimes they'll help us with that decision as well. Like I said, some are very comfortable with palliative care because maybe that patient has been a patient of theirs for 20, 30 years, and they want to see them right to the end. Often though, as well, they'll use a palliative care as a consult, but the family doctor still remains the primary caregiver and just consults with the specialist if a symptom arises that cannot be controlled, or if they just have any questions. So it's a bit of a combination.
Hi, can you hear me?
Yes.
Yes.
I have a couple comments. My name is Rachel. Somebody put in the chat, would the surprise question be helpful for non-cancer diagnoses? And personally, in my experience, I've seen it used very valuably in non-cancer diagnoses, simply because, you know, as Julie mentioned, it is difficult to prognosticate when it is not a cancer diagnosis, but there are specific, disease predictors of a decline, and specific non-disease specific predictors that are just general indicators of decline that we see in non-cancer diagnoses that can be red flags for us. And so when we start to see some of those red flags, we as the care team involved with the patients can ask ourselves and reflect on that question. Would I be surprised if they died in the year? Would I be surprised if they died this season? Would I be surprised if they were alive in a year? When we start seeing some of these predictors of decline, I have seen too that the tool is very valuable when it's used in the community by non-palliative expertise. So those practitioners that are general practitioners that maybe don't have the expertise to be able to recognize when someone is getting closer to end of life, or where some of those red flags may not be as evident or as clear if they're not seeing it all that often. So when you're seeing, appetite dwindling, frailness being present, weight loss without purpose, needing more help on a daily basis compared to what they were. So changes within 3 months, 6 months, that the practitioner or even the nurses themselves can ask these questions, reflect on what they're seeing, these changes that are seeing, and then be able to initiate referrals to maybe home care or referrals to some additional supports to be able to get them more support where they're at. That's where I see sometimes the value in asking this question, to be able to link the services that they need.
Carrie Lynn, you have a question?
Hi, I want to thank you both. It's actually more of a comment, and then I was hoping that maybe people might have something to contribute. What I really appreciate from both you and Nancy today is this idea that language is so important. And I think what asking the question, and as Rachel's just broken down, even looking at things in terms of 10 months, 6 months, 3 months, I think what that can really circumvent is that pushback you get from a GP or a doc in the community who says, oh, we're not ready for that right now. Or, I mean, and professionally and personally, I've been witness to that situation where the palliative care team is sort of this on hold situation, and no, we'll access that. And I've seen patients and clients say, oh, if you call in the palliative care team, of course you're giving up on me. So I like this idea that you take out those pretty what have become really loaded terms like palliative care team. Even to the point where at Sick Kids, they don't call themselves a palliative care team because of the connotation that the term palliative comes with, that society's kind of embraced. And really, it breaks it down to, what are we actually seeing here in front of us, and what are the ways that we can respond to this patient, so that we're going to, as Rachel broke down just now, meet that patient wherever they are on their continuum, right? Not just like, no, it's not time for that. Yeah, let's open that up and really look at all of those ways that tool can be used. So yeah, I think that's a really welcome conversation that you've started here.
Thank you, Carrie Lynn. Thank you. I recently read an article, Living Long in Frail Health, and by Joanne Lynn, and she speaks to really historically on how many years ago people died at home, and it was a natural process. So because it was a natural process, people talked about it. Now we're building language again. As time moves forward, we're building this language in an attempt to normalize death and dying. So I think that's really important when we talk about the surprise question and we talk about making new norms for people. That's perfect, Carrie Lynn, when you talk about people that, oh, he's not dying yet. Well, he's doing nothing but dying, right? And I think by just bringing these questions forward, it brings us together as a group as well. And it really helps us move our purpose forward. So I encourage all of you in your practice, challenge yourself, challenge your coworkers, use these questions. Use these questions. What am I hearing from other people? Are you using these questions in your practice?
Inga, you have your hand up?
Yes, I did. Thank you, Carrie Lynn, for bringing this up, because I just come from another meeting where I had a similar, actually twice in one meeting, happen where I would like the rest of the group to be involved, where it was said this person is not ready by the MRP. And thank you for Nancy and Julie for bringing this up, because I am going to be more cognizant of using that surprise question when I have conversations with even a palliative team. I know the amount of staff that is out there to do palliative care properly. We need so many more people. We don't have enough bodies to even do it. But I think we can use this question to really advocate for the people that we're taking care of, to make things as good as we can make it, and have a team approach, a multidisciplinary team approach for them. But thank you very much.
Mm-hmm. I totally agree. I've had this issue occur over the last couple of months where you get pushback that, no, this person is not ready. They're not palliative. And meanwhile, they do end up dying within 3 months, many of them, who, it's been kind of pushed by others, by social work or nursing, not necessarily the MRP, who will not agree that they're palliative, yet the social worker will get consent, and then I'm in to see the patient. This is inside the hospital. And so there are some physicians who are very open and others who are not. But yes, this question, the surprise question, it has been implemented within the hospital. I haven't necessarily used it, but I have had one physician tell me that that's how he bases sending his palliative referrals out, because he questions himself every time the surprise question. So yes, it's totally opens everything up to help us, you know, provide better quality of life to these people who really need our assistance. And it doesn't matter where they are in their illness. Thank you.
Thank you, Catherine. I'm thrilled to hear that there are physicians that actually, and that they're sharing with you that they're using this question. When I first joined the palliative care team up in Collingwood, I remember on my first or second visit to the hospital, having a conversation actually in the stairwell with a family physician who, he's a wonderful, wonderful, wonderful man, and he really does encompass all of the medical staff and takes them underneath their wing. And I remember having that conversation one of my first visits to the hospital. And I felt that I was teaching him something. In all reality, he was teaching me, right?
Right. Neat.
I know in Midland, we've got a couple of our palliative specialist docs that when we do rounds, they'll just bluntly tell us, yep, they failed the surprise question, let's get moving. And it's like, great. You know, to me, it like we're not assigning a number or a time, but in a way it kind of is. You know, if we're talking less than 12 months, we need to get a move on things. And you know, there's always wait lists for any type of service out there. And, you know, the sooner we can get the process moving, the better quality of life we can give to our patients.
Yeah, for sure.
I think as a nurse at the bedside and community too, it allows you to reflect on, you know, why you may be going in and seeing that person at that point in time, and why on the care plan it lists out, you know, please have a discussion around advanced care planning or goals of care, or, you know, ask them who their substitute decision maker and things like that. You know, if I were a new nurse and working in community and I'm seeing a patient and family for the first time, and I look at the care plan of what, you know, someone is asking me to do, and I have, say, a diagnosis on paper, and I don't really have an understanding of why would they be asking me to have these conversations when this is their diagnosis. But then when I actually go in and physically see them and do my assessments, I can ask myself as a nurse, you know, would I be surprised? And then what I'm seeing I've been asked to do will make more sense to me.
Sorry, go ahead, Kathy.
I'm sorry. I'm not very quick on the little actions on here, but anyway, I totally agree with this whole situation. This will be really interesting for community nurses, this surprise question, because community is very task oriented. So often nurses are going to visit people and they're just doing PICC line care. And these people are receiving chemo or radiation, but sometimes patients never really tell the nurse, and the nurse in the community is somewhat uncomfortable to ask that question, whether this is curative or palliative type chemo. And once the PICC line care, the PICC comes out, the nurse will discharge the patient, and there they are, and they don't have any kind of, you know, supports happening. Where I believe that if the nurse was to ask this question in her head and have a conversation with the patient, she would realize that maybe her care needs to remain in the home, and she can, I just think that this would be really helpful for community nurses. I agree.
Oh, for sure. I work community extremely casual, and I do see that a lot. The care, once the physical care, the PICC line is done, they kind of drop them. And it's like, no, you could keep them on and just do a wellness assessment every couple of weeks or once a month even. Just leave them in the service, but then somebody is checking on them, right?
Correct. Yeah.
I often wonder if perhaps our visiting nurses, whether it's lack of confidence or many new nurses, so lack of experience, and perhaps because they have lack of experience, How many conversations have they actually had the opportunity to initiate and to see through from start to finish? Again, I think our mentorship is a huge piece of allowing that to happen.
Right. They're also, their caseloads right now are so high, they don't have time to sit in a home and have a conversation with the client. So I've often promoted with them, when you're doing your PICC line care with them, or whatever it is you're doing with them when you're visiting, you should be chatting about these, try to have conversations while you're doing that work, so that your time isn't squandered in the home. But some of them are carrying very high caseloads, like for visiting, and then there's the geography of it all too. So they're pretty busy, and it's hard for them. But hopefully, you just keep discussing with them.
I find
Yes,
too,
we do need to keep talking.
I find too that I had an experience yesterday when I was doing a home visit with a patient and her daughter for the first time. And just the surprise question was certainly discussed, but it was the changes that were happening so rapidly. And I often pose the question when, the family, this daughter was just wondering, I just want to know, is this the end of life phase that she's entering, just for her planning purposes, because also caring for her elderly father with advanced dementia, her plate was just overflowing. And, talking about changes that had happened, and the surprise question we talked about, and the indicators of the many different chronic diseases, and how was this person even 2 weeks ago, 3 weeks ago, compared to now, and projecting forward, and what might we be facing. And
Yeah.
Isn't that a great tool? When you can actually speak, Charlene?
Yes.
When you can actually speak to really the domains of care, and you're actually allowing that family to be in that space with their loved one for a moment, reflecting upon what they did see a number of weeks ago, so they themselves can come.
Like a paper copy of the prognostic tool, and it had the surprise question and the different, and it just gave a real visual. And I ended up leaving that with the daughter just to review on her own time, because she's just having such a hard time, kind of wrapping her head around what's happening and so quickly. And
yeah,
that's fabulous. Do we have any other disciplines that are with us today that are using the surprise question?
Today, what was?
Someone's mentioned the surprise question being used in the emergency room for COVID patients. And I think that would be absolutely fabulous. That would be fabulous. They're in a very critical period of their life, COVID and long haulers COVID. So even if this is not an expected death within even the next 3 months, being able to project ourselves forward and give the family education related to that decline, however quick or delayed it may be, it's information, it's good information for them, right? And it brings them onto the same page, right?
Absolutely. And I think too, would be beneficial just in general in the emerge for COVID specific population, but for everyone. Because of COVID, many people have delayed seeking attention, help. And so therefore it becomes a crisis, and then they end up in the emerge. So having that awareness in the urgent acute setting to take a minute and ask yourself that surprise question would really help direct the care.
I so agree with that, Sue, because sometimes it takes a sentinel event or, a trip into the emerge, to bring attention to the limited resources that they're accessing in community. And so, the team asking the surprise question of themselves when the person arrives allows them to be able to link them with the appropriate resources to get them back home as soon as possible. Even if it's a direct turnaround, because the reason they landed there is because of limited resources or accessible team out in community. It just highlights them to assess what the needs are and then to do something about it.
Yeah.
I see Trevor is coming to us from social work, and I'm just wondering, he says, my team does use the surprise question and it helps guide my work as a social worker as future planning. I'm so glad to hear that. See how it does cross disciplines, right? Such a simple tool.
Nancy and
Things
Julie,
don't have to be complicated.
I have a question.
Sorry, Linda.
That's
Yes.
okay. In your experiences, and in your presentation, you mentioned using the surprise question with other palliative care tools. So perhaps maybe PPS or ESAS. So if you have these tools available and physicians have these tools available, what do you feel the barriers are to actually asking the surprise question? Because really, it isn't a surprise.
Mm-hmm.
Do you see what I'm saying? Or
Yes, I do.
asking? What do you think the barriers are?
I think from seeing from community aspect, and I'm an old hospital nurse too, I think it's just knowing what to do after you answer that question. What tools do I use? And I think if, we can educate other people on using PPS and ESAS and the clinical frailty scale, the depression scale, the CAM scale, all those extra tools, then we can present to the doctor an argument to say, no, this person really is palliative. And this is why. I have done the assessments with all of the tools. These are my findings, which, even the family or the patient can even say, you know what, I've noticed a deterioration over the last few months. Well, when we further assess that, and then go to the doctor, we just have more proof in our pocket to say we really need to get a go on this palliative approach to care.
I wonder too sometimes if the doctors feel that by talking about that, and the surprise question, do they feel that they're maybe going to upset their patients and families? Are they taking away their hope for the future?
I think so, Charlene, because I just recently had a client, the nursing home in Collingwood got consent to do a palliative consult with me from the husband of the resident. And he goes, oh, so you mean she's dying now? So she had to explain the whole early approach to care. Let's just get Julian to do an assessment and we'll just monitor, because the home had noticed changes. And yes, he admit that there has been some changes, but yeah, I think even the doctor never even thought to get palliative care in the long-term care home, because they've always done it. But I've noticed a lot of the homes, because I promoted it, that, we really could use the expertise in here as well. And staff turnaround in the homes is huge. There are, new grads, etc. But yeah, once he said, oh, I'm going to have the palliative nurse consultant come in, he's like, uh-oh, like, is this it? Like, how much longer do you think she has? And, so I see that with physicians as well. They deem them palliative when they only have weeks left. And that's really end of life, not palliative. And it really should have been started earlier, because I've had a lot of crises and they get me involved and two days later they're gone. So
I also wonder if there's a component to the patient-physician attachment. In lots of these instances, these are family doctors, right? Meaning they have cared for an entire generation, sometimes 2 generations. And then they have a clear attachment to their patients and to the outcome of the care that's provided for their patient. So if they if they themselves are not well educated in what actual palliative care is, it being approached care, as Julie said, not end of life care, then I think that that does affect the conversations that they're going to have with their families. And I hope that answers your question, Linda, to what some of those barriers may be. For myself, I do back it up to their comfort level. Sometimes time, I think, is a factor. If they carry a very heavy caseload, it does take time to have these conversations. And when you're sitting with someone eye to eye and opening their heart to you as you are to them, this is not a conversation that you can rush. So that may also be a barrier. Yeah, I hope that answered your question.
It did, thank you. Just also, I mean, Carrie Lynn did hit on this. It's just that so many people come either from home into hospital or from hospital wanting to go to hospice when they're a 10 or a 20%, when actually that's totally avoidable, and they should be coming at at least a 30%.
Right.
I think the tool can be helpful too, as a little bit of a reminder. So, you know, a lot of times we talk about, you know, pilot programs that are talking about quality improvement and things like that. And, you know, to use the surprise question as a bit of, you know, this is what we're going to initiate into our practice. And we're going to say to ourselves, every person that we see today, we're going to reflect on this question. And if the answer is no, then that will direct us to this level of assessment. And if the answer is yes, I would be surprised, then it sort of directs you into a different line of conversations, you know. And if you start putting it into practice with those that you come across in your daily work, it's a bit of just a reminder. And once you start using it as a trigger for that reminder, then that will normally start happening even without that reminder that's present.
Carrie Lynn, you have your hand raised.
Yeah, thanks. I just wanted to circle back to something that Linda said too. I think it was Linda, it might have been Rachel, apologies, but I think we're very good at really understanding multidisciplinary approaches, because of course we come from all spaces and areas, and we contribute to a case. What I think would be really valuable is if interdisciplinary wise, physician specialists could make space at the table for the palliative care specialists. So, there's that interesting idea that, you've got somebody who's got their GP, as Nancy has said, and possibly a GP with whom they've had a relationship for many years. You introduce an oncologist, a urologist, other specialists, making space for the palliative care doc in those conversations from, as you say, early onset, really contributes to that idea of an interdisciplinary, where you've got this constellation of people on the care team, rather than, oh yeah, we better bring a chair forward for the palliative care doc. And as Julie quite rightly said, there are situations where that happens, days before somebody dies, or, the palliative care team consult is scheduled after the death. In a situation I had, a man living with ALS, and I mean, the understanding of his trajectory was quite apparent, because he was following a fairly familiar trajectory. Of course, went into the emerge with COVID-like symptoms, died, and the palliative care consult was actually ironically scheduled for the weekend after he died. So again, I think it's really focusing not just on multidisciplinary, but also interdisciplinary, and making that language, as Nancy said, making that language normative, right? That's what we do. The palliative care doc has been brought into the situation.
Mm-hmm. Good point. Very good point. I'm not sure if everyone's keeping up with the chat, but I do see that there was an entry by Amanda stating that she had used this surprise question with her mom as her grandmother fell ill, and how that helped to break the ice. That's tremendous. that is tremendous. That is success. Well, I hope you have all enjoyed our chat today. I know I certainly have. Just being in a room with people with like interest helps us propel ourselves forward, and it certainly helps propel our purpose forward. So I encourage each one of you today to take this message with you. Practice it.
Encourage others to use it.
Thank you both so much for your time today. It's been an absolute pleasure having you both here. And just so everyone knows, we will be sending out a link to a survey as well as a copy of the recording from today's chat. We hope to see you guys again soon.